for the informative session. Now we'll move on to the second session. I request the chairpersons, Dr. Shivanand sir and Dr. Balasubramaniam sir, to come on dais. Dr. Shivanand sir, presently Professor and HOD, Department of Anesthesiology, SIMS, Shimoga, has done MBBS and MD from JJMMC Davangere, and sir has served as ISA Shimoga chapter president and conducted CMEs in Shimoga during his tenure. He has got Best States ISA Branch Award in the year 2022-23. Sir has got 6 publications to his account, and his areas of interest, regional anesthesia and obstetric anesthesia. We welcome you, sir. Dr. Balasubramaniam, PK, is a consultant anesthesiologist, Manipal Hospital, Mysore. Sir is certified in CTLS course held at Bangalore, underwent training in regional anesthesia and trauma care at Ganga Medical Center and Hospital, Coimbatore. Certified in BLS and ACLS, done fellowship in interventional pain management in December 2009 at Daradia Pain Center, Kolkata. His areas of interest are ultrasound guided regional anesthesia. We welcome you, sir. I request the chairpersons to introduce first speaker of the session.
Yeah, welcome all to the second session. I take this opportunity to introduce Dr. Shalini. She is currently the Assistant Professor in the Department of Anesthesiology, Mysore Medical College and Research Institute, Mysore. She did her MBBS from Adichinjanur Institute of Medical Science, BG Nagar, Belloor, and MD from MMC. And she also completed a DNB in 2015. She has a total teaching experience of 10 years. And coming to her academic achievements, she has secured a first rank and university gold medal in her MD exams conducted by RGUHS. And she was also awarded the best outgoing MD student. And she has to her credit 8 national and international publications. Over to Dr. Shalini.
Thank you, sir. Good morning, everyone. For the next 15 minutes, I'll be talking about the cardiac cycle and anesthetic implications. The objectives for today's session: definition of cardiac cycle. We'll be learning about the phases of cardiac cycle, the Wiggers diagram to correlate all the events in the cardiac cycle, and the left ventricular pressure volume loop to know the changes in different clinical scenarios. Now, what do you mean by cardiac cycle? The cardiac cycle describes a series of mechanical and electrical events that occur during one heartbeat. Each cardiac cycle is initiated by the generation of action potential in the SA node, which is then carried to the AV node, and then from the AV node to the bundle of His and through the Purkinje fibers to the ventricles. In a normal adult with a heart rate of 75 beats per minute, the normal cardiac cycle lasts for 0.8 seconds. And remember, both atria and ventricle go through a series of events in this 0.8 seconds. Now, if you see this, a circle or the cycle, now each part is 0.1 seconds, 0.1 second, a total of 0.8 seconds. Each cardiac cycle can be divided into 2 phases: the atrial events, which last for 0.8 seconds, and the ventricular events, which again last for 0.8 seconds. Again, the atrial events are divided into systole, which lasts for very brief 0.1 second, and the diastole for 0.7 seconds. The ventricular events, systole lasts for 0.3 seconds and the diastole for 0.5 seconds. Now, as you can see, the atrial systole is very brief, for 0.1 second, followed by the atrial diastole, which is for 0.7 seconds. Now, once the atria has finished its systolic function, it passes on the blood to the ventricles, and the ventricle starts contracting, which lasts for 0.3 seconds, and the rest of the 0.5 seconds is ventricular diastole. So, the same has been depicted in a simpler way in this diagram. So, atria mainly acts as a primer pump for the ventricles, and the ventricles acts as a major force of power for pushing the blood into the pulmonary circulation from the right ventricle and the systemic circulation by the left ventricle. So, as you can see in the diagram, there is a complete diastolic period of heart for 0.4 seconds. This is called a joint diastole, where both the atria and the ventricles are in a diastolic phase. So this is 0.4 seconds, which tends to reduce whenever there is increase in heart rate. We call it as tachycardia. Now coming to the main ventricular events, now as I said before, the ventricular systole lasts for 0.3 seconds and each ventricular systole go through 3 phases, that is isovolumetric contraction, the rapid ejection phase and the slow ejection phase. Now the ventricle, you can remember easily 0.3 seconds, so 3 phases. Ventricular diastole lasts for 0.5 seconds and the phases are protodiastole, the isovolumetric relaxation, the rapid filling phase, slow filling phase and the filling due to atrial systole. 0.5 seconds, 5 events. So we'll go through each phase one by one. Coming to the isovolumetric contraction phase. So I want you all to concentrate on this pressure volume loop of the left ventricle, which I'll be putting in all the further slides. So let's start with this point, that is the mitral valve closure. So once the mitral valve closes, there is isovolumetric contraction phase. Now, when do we say it is isovolumetric contraction? It is the time interval between the closure of mitral valve and the opening of the aortic valve. So this phase is the isovolumetric contraction phase. Now what happens here? The volume remains the same, but the pressure inside the left ventricle rises sharply. It is a phase where all the cardiac valves are closed, and it correlates with the QRS complex on the ECG. And note that the left ventricular pressure, which was very low at the basal level of 8 millimeters, rises to as high as 80 millimeters of mercury during this phase. So it's a very negligible time, it takes very negligible time of 0.02 seconds. Next comes the rapid ejection phase. Now the aortic valve has opened here. Now the blood is pushed from the ventricles to the aorta through the rapid ejection phase. So this occurs when the right ventricle and the left ventricular pressure exceeds the pulmonary artery and the aortic pressures. It pushes 2/3 of the blood into the aorta during this phase. So as you can see, this is the rapid ejection phase. Takes 0.1 seconds. Next is the slow ejection phase. So here, 1/3 of the remaining blood in the left ventricle is pushed into the aorta during this phase. As you can see, this is the slow ejection phase. Now note that the pressures have increased from 80 millimeters of mercury to almost 120 millimeters of mercury, and then there is slow ejection of blood after 120 millimeters of mercury. It takes about 0.2 seconds. So this is about the ventricular contraction. So right from the mitral valve closure to the aortic valve closure, here it is the contraction phase of the ventricles. Now we will be concentrating on the ventricular diastolic period. Now what happens? The first phase is the protodiastolic phase. Now it is almost negligent or almost non-existent phase. During this phase, what happens? There is some amount of backflow of blood from the aorta to the left ventricles, and hence, because there is closure of the seminodal valves, there is production of the second heart sound at this phase. Now, as you can see, the next phase is the isovolumetric relaxation phase. Now, what happens here? Now you see that the aortic valve closes at this point and the mitral valve has not yet opened. So this phase, where from the aortic valve closure to the opening of the mitral valve, this is the isovolumetric relaxation phase. What happens? Again the left ventricular volume remains constant, but the pressure inside the left ventricle falls drastically. So this is a very important phase. As in isovolumetric contraction phase, here also in the isovolumetric relaxation phase, all the cardiac valves are closed so that the heart drops its pressure to the lowest possible. So next, again, it's a very negligible time. Then comes the rapid filling phase. Now, here we have seen that the mitral valve opens at this point after the isovolumetric relaxation phase. Then the left ventricle starts filling itself from the blood that is being pushed from the left atrium. So this mitral valve opens and there is pushing of blood from the left atrium to the left ventricle due to gravity. 50% of the blood which is collected in the left atrium is pushed into the left ventricle during this phase. Next comes the slow filling phase. Now here there was rapid filling. Now this part is the slow filling phase, also called the diastasis phase. 30% of the left atrial blood is pushed into the left ventricle during this phase. It is the longest phase of the cardiac cycle, and whenever there is tachycardia, it is this phase which gets shortened during the diastole. But however, the left ventricular filling doesn't get hampered because almost 50% of the blood is already being pushed in the rapid filling phase. Now, the last part of the diastole is the filling due to active atrial contraction, which we also call the atrial kick. Now, what happens? This is the last third. Again, what I told you, there is active contraction of the left atrium, which pushes the remaining blood in the left atrium to the left ventricle. About 20% of the blood, which was still remaining in the left atrium, comes to the left ventricle. Normally, it is not very significant in healthy individuals, but this becomes very important whenever there is tachycardia as in exercise, or in stenotic lesions like mitral stenosis, or in patients with cardiac failure who have a decreased preload to the left ventricle. So even this 20% of the left atrial volume matters a lot for these patients. So to summarize these events, this was the events what I told. The mitral valve closes, the aortic valve has not yet opened. During this phase, the left ventricle undergoes isovolumetric contraction phase where the pressure builds up but there is no volume change. Then is the rapid ejection phase where the blood from the left ventricle is pushed into the aorta. Then the slow ejection phase. Now this is where you get your systolic blood pressure. Now then the aortic valve closes after the systolic period of the ventricles. Then there is diastolic period. Initially there is isovolumetric relaxation where the pressure drastically drops to basal level, and this is isovolumetric relaxation phase. After the isovolumetric relaxation phase, the mitral valve opens. There is rapid filling of the left ventricle from the blood from the left atrium, and then the slow filling phase. Last part is the atrial systolic phase. These events of the cardiac cycle can be dealt with the changes in the pressures, the changes in the volumes of the different chambers, changes in aortic and pulmonary artery, the heart sounds, and the ECG. Now these are all summarized in a diagram called Wigger's diagram, which would be very popularly known. This is by American-born physiologist Carl J. Wiggers, almost 100 years back. He came up with this diagram to correlate all the relations between the pressure and the volume over time, along with the electrical heart activity of the heart. Now, slightly complex diagram. I'll just split it in each slide so that it will be easy for you all to understand. So, as you can see, one second. So here, this is the heart sounds. This is the ECG part. This is the ventricular volume. The blue one is the ventricular pressure. Here, what you see, the small waves is the aortic, atrial pressure, and this is the aortic pressure curve. Now, whenever there is a atrial depolarization, now what is atrial depolarization is depicted by the P wave. After the atrial depolarization, the atria contracts. So when there is atrial contraction, you see a wave, which is a positive deflection in the atrial pressure curve. So the next slide is regarding that. So as you can see here, the atrial pressure, So after the atrial contraction, I'll just show here, it is easy for you all. The A wave appears after the P wave in the ECG. So this is due to the active atrial contraction or the atrial systole. Next comes the C wave. This is seen in the isovolumetric contraction period, where just before the ventricular contraction, where there is the AV valves are slightly pushed upwards towards the left atrium because of the active ventricular contraction, which leads to a positive deflection in the atrial pressures. And then the last wave in the atrial pressure is the V wave. It is due to the ventricular filling in the diastolic period. The next graph is about the aortic pressure. Denote that when the aortic valve opens at the end of isovolumetric contraction period, there is rapid ejection of blood into the aorta, and hence you see a positive deflection in the aortic pressure curve. And after it reaches the systolic pressure of 120, the pressure starts dropping. Now this is also called the incisura. This part, a small notch is seen at the relaxation phase. This is called the incisura. This is because of the slight increase in pressure in the aorta due to the backflow of the blood from the left ventricle. And after that, the aortic pressure constantly falls to the basal level. Here, as you can see, it slowly falls to the basal level before the next LV contraction. Now this is a graph showing the ventricular pressure and the ventricular volume. As you can see, in the isovolumetric contraction period, the pressure rises in the left ventricle, but the volume is same. In the ejection phase, there is rapid ejection of the blood, so there is a positive deflection, the pressure rises and then falls. However, the volume starts decreasing because the blood is ejected out of the left ventricle. In the isovolumetric relaxation phase, the pressure drops drastically, but the volume is the same. As I said, isovolumetric contraction, there is no change in volume in both the phases, only the pressure changes. Then there is rapid filling phase and the slow filling phase, where the pressure almost remains the constant in left ventricle, only the volume goes on increasing. So this is the next cardiac cycle it is preparing for. So this is about the Wiggers diagram. Again, if you put all these events together, what you get is a Wiggers diagram like this. I have simplified just taking each wave so that it's easy for you all and it doesn't confuse you all. Okay. Now, what are the clinical implications of this cardiac cycle? In regurgitation lesions, remember, there is no true isovolumetric contraction or the relaxation phase. Now, as I said already, in the isovolumetric contraction or the relaxation phase, all the valves of the heart has to be closed. But what happens in regurgitant phase, there is leakage of blood through the regurgitant valves. So that is why there is no isovolumetric contraction or the relaxation phase. Now, in the isovolumetric contraction phase, there is closure of the atrioventricular valves, which leads to production of the first heart sound. During the protodiastole, when there is closure of semilunar valves, there is second heart sound, what we hear. During the rapid filling phase, the third heart sound is heard. And during the atrial systole, the fourth heart sound is heard, which is not normally heard in physiological conditions. Only when there is a stiff atria, we hear the fourth heart sound. Now, as you can see in the graph, this point is called the end diastolic volume, and this is called the end systolic volume. The difference between the end diastolic volume and the end systolic volume is the stroke volume, which is normally about 80 ml. And the ratio of the stroke volume to the end diastolic volume is the ejection fraction, which is normally around 60 to 80%. The LV pressure volume loops, a brief thing on that. The area of the diagram, this is the area under the LV pressure loop. This depicts the stroke work done or the work done by the left ventricle. Now the width of this diagram shows the stroke volume, and the height shows you the afterload of the heart. The clinical importance. Now, whenever there is an increase in preload, there is shift of the LV loop to the right, and whenever there is decreased in preload, the curve is shifted to the left. Now, what happens with the afterload? Whenever there is an increase in afterload, the height of the LV pressure volume loop increases, whereas when there is a decreased afterload, the height decreases. So, the same has been told here. During exercise, what happens? The end diastolic volume, end systolic volume, and the stroke volume, everything increases, but the shape of the LV pressure volume loop doesn't change, but it gets bigger in size, that's all. So, this compliance of the LV also doesn't change whenever there is exercise or increased stroke volume. What happens when there is a diastolic dysfunction? Now, as you can see, this curve is the end diastolic pressure volume relationship. Whenever there is decreased compliance of the left ventricle, this curve gets steeper. So, whenever there is diastolic dysfunction, compliance is a reciprocal of this slope of what I told, end diastolic pressure volume relationship. So, this upward slope tends to say that there is LV dysfunction. So, in mitral stenosis, what happens? The end diastolic volume or the preload is decreased, leading to as I say, when there is a preload decrease in preload, the pressure volume curve is shifted leftwards because of the decrease in preload. In regurgitation, as I said, there is no isovolumeric contraction or the relaxation phase. There is no straight lines. There is bulging of all the lines in the LV pressure volume curve. So there is no isovolumetric contraction or relaxation. The end diastolic volume is increased, so the width increases. Afterload is decreased because the height also decreases. As you can see, the height is also decreased. In aortic stenosis, there is an increased afterload because of the stenotic aortic valve. So there is increased afterload. So the curve gets taller and narrower and hence the stroke volume also decreases. There is increased afterload. Okay, so there is increased end systolic volume also. Aortic regurgitation, again in all the regurgitations, there is no isovolumetric contraction or relaxation. There is bulging of this loop leading to increased width of the LV loop, leading to increased LV volume. Yeah, the width is increased. So to conclude, to understand the mechanical performance of the heart, we need to have a thorough knowledge about the phases of the cardiac cycle. And cardiac cycle is a highly coordinated process that is dependent on the tight choreography events, and any derangement or disruption in these events can be detrimental. So these are my references. Thank you for your patient hearing.